Well, good afternoon, everyone. Thank you for showing up for another session. This is our fourth session in our summer brown bag series. We're glad to see you all in person, and those of you that are here online, welcome. Today we have an exciting presentation. Actually, they've all been exciting, but today we have an exciting presentation. I've gotten lots of emails and comments about today. So again, we're really excited to follow up with you. I am going to introduce the moderator, but before we get there, I just have a couple of housekeeping items. When we hit the Q&A session, we will, the ceiling has microphones, so they're not on now, so go ahead, you can whisper amongst yourselves, but once it actually starts, you won't need a microphone brought to you, so that you're not looking for that. Our speakers will have their microphones. And if you take a look at the Department of Psychiatry's website, you will see our follow-up information for the following 2 weeks and for the rest of our series. And so I'd like to introduce to you today our moderator, and most of the people in this room and probably online are familiar with her. You probably see her name in front of me. That's not me, but Dr. Telva Olivares is going to be our moderator, and she will introduce our panel today. Telva is the Associate Vice President of Health Outcomes Optimization. She's also the Senior Associate Dean of Health Outcomes Education at SMD. But most importantly, she's a professor of clinical psychiatry, and she's one of our very own. So please join me in welcoming Telva, and she will make the other introductions.
Thank you. Thank you for that. I have to wear glasses now. Thank you for coming to this series. Today we have assembled a panel of professional experts who help us better understand the new medical aid in dying law that goes into effect today, after a wait period of about 180 days since Governor Hochul signed it into law in February. This wait period was intended to be dedicated for healthcare systems and practitioners to learn and educate themselves in preparation for today. We hope that today will help all of you learn not only more about the law itself, but as clinicians, we hope to arm you with resources to help you better educate your patients and yourselves. Let me begin by introducing Dr. Rob Horowitz, who is on screen and via video. Rob is trained in internal medicine, pediatrics, hospice, and palliative medicine, and serves as the chief of the palliative care division at Strong Memorial Hospital from 2015 to 2023. Together with his colleague, Tom Carroll, he co-developed URMC's Advanced Communications Training, or ACT program, which helps clinicians deepen their skills in clear, compassionate communication with patients and families facing serious illnesses. In 2023, Dr. Horowitz with Dr. Mark Swager introduced the PALCAP program at UR Medicine. It is among the few palliative care embedded psychedelic assisted psychotherapy programs in the United States, and it helps patients to ease their psychological and spiritual distress that can accompany serious illnesses and support quality of life throughout its course. Next is Dr. Yeates Conwell, who's professor in the Department of Psychiatry. His departmental roles have included being vice chair, director of geriatric psychiatry program. He is co-director of the Center for Study and Prevention of Suicide and director of the University of Rochester Medical Center's Office for Aging, Research, and Health Services. His primary focus for most of his career has been to research our risk factors for suicide in second half of life and their implications to service system redesign, with a particular emphasis on the design and implementation of preventive interventions in community settings. Next is Dr. George Nasra. George is a professor of clinical psychiatry at URMC. I should say U Rochester Medicine, where he serves as chief of the Division of Collaborative Care and Wellness and medical director of Behavioral Health Partners. He is now the new associate chair for adult ambulatory services for the department. He is trained in general adult psychiatry, forensic psychiatry, and psychosomatic medicine. Dr. Nasra's career interests include collaborative and integrative care, as well as increasing access to psychiatric services and reducing stigma for mental health. He has dedicated his time currently to developing new models of care, integrating between psychiatry and different areas of medicine. And last but not least, Mike Scharf. Dr. Mike Scharf is currently the Mark and Maureen Davitt Distinguished Professor of Child and Adolescent Psychiatry and the Psychiatrist in Chief at UR Medicine's Golisano Children's Hospital. He leads the Division of Child and Adolescent Psychiatry as Associate Chair of Psychiatry for Children and Youth, overseeing all child mental health services for UR Medicine. He is the Executive Director of Project Teach, a child psychiatry and perinatal psychiatry access program, providing education, resources, and clinical consultation to clinicians across the New York State. Most of all, Dr. Scharf is dedicated to ensuring that access to quality mental health care for all children and adolescents who need it. So without further ado, Dr. Horowitz, can you get us started?
Yeah, thanks so much for the intro, Telva. I'm sharing screen on webinar. Is my screen shot visible behind my friends there as well?
Not. Is that your screen? Yeah.
Yeah, you can see behind then, George and Yeates. I can't see your
Yes.
projected. Yeah, that's visible. Okay.
Okay.
Yeah, to the audience there or
Yes.
okay. Okay, great. So yeah, and I'm sorry I can't join you in person. I'm quarantining from COVID, and while I love to share the space and the air with my friends, this is air you don't want me sharing with you. So let me share with you a bit about the reality of medical aid in dying. And I should start by saying the interest here is about more than the law. So the law becomes active today, but much of what we're talking about has to do with many factors affecting seriously ill folks separate from and preceding engagement with the law itself. So as I meet with hospitalists and oncologists and primary care folks about their engagement in medical aid in dying, I'm asking them to think about and you to think about how you'll respond to seriously ill patients who say any of these things. These are real quotes. I'm done. Take me behind the barn and shoot me. We treat our dogs better than this. You may hear this is what our nurse manager on the palliative care unit said a neighbor asked her when they crossed in the street. I want to know how to get the big needle when the time comes. No needles in MAID and aid in dying, by the way. Or tell me about medical aid in dying. Any of these may lead to conversation around the law, but any of them may be seen as something else and want to open up consideration around that. So to contextualize medical aid in dying in terms of its proportionality to dying in the United States, somewhere around 3.2 million people die every year in the United States. Around 15% of that, plus minus, are sudden deaths, usually sudden cardiac deaths, traumatic deaths. Creative language here, 10 to 25% of deaths in the United States, depending on how this is defined. No epidemiologic way of tracking this super closely are what I'm calling mortality allowing deaths. These being deaths in people who are anticipating their death and saying no to one or another intervention. It might be, as this woman proclaimed, DNR, DNI. It might be somebody stopping a ventilator, not pursuing further chemotherapy, turning off the dialysis. And of those, a small proportion of them, as best as can be tracked, and again, there's no national way of tracking this, maybe 1 out of 200 deaths in the United States is medically supported intentional deaths. By that, I'm referring to what our friend Tim Quill referred to 30 years ago as palliative options of last resort, of which aid in dying is one. I named him here now. For those who don't know, I've been doing something of a talking circuit about aid in dying because we in palliative care are so deeply involved in conversations with serious ill patients who are distressed about their future. It would be Tim who would be standing here now if I weren't. But Tim, I have permission from his family to share with you. He has dementia. So our friend and mentor, Tim, is no longer able to speak further about this with you. And neither am I here, frankly, to cheer the work he did. I do personally stand as one of the physicians who will serve as a comprehensive medical aid in dying participant. But one of the wonderful things about Tim was he invited conversations, in addition to establishing our palliative care unit there, he invited conversations from across the moral stances. He engaged in debate, and following him and honored by him were people who supported his stance and people who stood against it. And it's important to acknowledge that amongst us in palliative care, amongst you in the audience, are people who may be cheering this and people who are jeering this, and yet this is a reality before us now. The law is live today. So of those palliative options of last resort, or what I'm calling medically supported intentional deaths, two I need to distinguish. I name euthanasia here to distinguish it from medical aid in dying. The language in Canada, medical assistance in dying, MAID, is often conflated with what the US jurisdictions talk about in medical aid in dying. Same acronym, MAID. Euthanasia, medical assistance in dying, legal in Canada, Australia, you'll see here some European countries, are situations in which a suffering patient who is not necessarily terminally ill requests to die, and the clinician administers the lethal medication. I'm assuming lots of conversation before this, by the way. There's a lot more that grounds a person to even make the request. But that's euthanasia. Roughly 5% of the deaths in Canada last year were related to medical assistance in dying. Medical aid in dying is defined in the United States in every one of the 14 jurisdictions, even though there are differences between them. They all are unanimous in this being applicable for patients who are terminally ill. And in these cases, the clinician, if they satisfy multiple eligibility criteria, we'll touch on, the clinician prescribes the lethal medication, which the patient self-administers. That's MAID, medical aid in dying, as we refer to it. I use the acronym just to save a few syllables and get a little bit more information in my remaining 15 minutes. The timeline in the United States, medical aid in dying, Oregon was the first state that legalized this. It became active in 1997, and subsequently over the next 29 years, 13 other jurisdictions and states joined those that support law for medical aid in dying. In New York, a bill was introduced 6 times before last year passing both chambers. And 1 year ago now, in fact, we were all getting together, George and I and many others, to talk about what this might look like. We've had about 12 years to do some preparing and are way ahead of the curve, even as we anticipate the reality coming soon. The law was signed 6 months ago, and yes, it becomes active today. This is a screenshot from news this morning here in Rochester. Dying Act takes effect in New York. Listen to that framing. So what's the projected impact of medical aid in dying in the greater Rochester region? These are guesses. The greater Rochester region, these 9 counties, comprise somewhere between 1.2, 1.5 million people, and around 10,000 deaths per year in the greater Rochester region. If in New York and in Rochester, as in other MAID legal jurisdictions, somewhere between 0.2 and 0.8% of deaths are related to ingestion of aid in dying medication, we're talking about perhaps 20 to 80 deaths from ingestion of aid in dying medicine in the greater Rochester area per year. Could be off substantially. Again, this is a guess just to anticipate and to proportionalize our anticipation here. We know that in MAID legal jurisdictions, about a third of folks who get a prescription don't ingest it. And we know that many folks who are on the MAID law process in their state don't get a prescription. So we're not sure if this is 50, 100, 200, 300 folks who actually are engaged in the MAID law process. I want to make clear, though, that we know that of those who pursue the process in earnest, many times that, 5 to 10 times that, are the numbers of folks who are considering it seriously for themselves. And many times that are the number of folks who are curious about what does it mean. Every time I speak with primary care docs, oncologists, others, I'm hearing them saying, yeah, my patients are asking, just as my nurse manager was asked on the street by a neighbor. This is not somebody who's seriously intending that for himself now, but MAID curiosity is out there. It's in the news. And so part of what we're striving to do is ensure that the medical center community be aware of this and not see every question about aid in dying as necessarily a need for an expert to engage in conversation about the process. So how not to have a serious illness conversation, I think you know this, but this is what the message is to folks out there who are looking at the statute as everything, looking at MAID eligibility based upon the law as the definition of a patient's medical situation. And if they check all the boxes, a prescription is forthcoming. It's clearly much more complicated than that. And so our message is and has been MAID inquiries are not checklist eligibility transactions, but rather they're invitations to explore unmet needs, explore the experience of suffering, fear, agency, and more. So how to do this, I won't belabor, but how really to do this means really exploring in depth the medical situation, the treatment options, the prognoses with and without treatments, exploring then the patient's values in that context, their hopes, their worries, their fears, based upon their faith, based upon their culture, based upon their lived experience, and maybe talking about MAID, the law. Motivations for aid in dying, this is from 12,000 recorded ingestions of aid in dying prescriptions across the country. You'll see most common are concerns about loss of autonomy, less ability to enjoy. And you might look at some of these, pain and other symptoms, representing a report from 30% of folks. This adds up to more than 100% because people have more than one reason that motivates them. Some of these are remediable. Some of them are addressable. Others maybe not so clearly, and we need to consider that possibility. So with all of this addressed, then we can talk about the potential for this person, whether aid in dying is appropriate to their values. And this is an iterative process. So let me tell you about the law now. So there's the MAID eligibility up on the top. Patient has to be terminal, meaning less than 6-month prognosis. They have to have decision-making capacity. They have to be fully informed of the law. This has to be an act that is voluntary, autonomous, not coerced, and the patient has to be able to self-administer the medication. This requires multiple steps, an eligibility evaluation by a MAID attending physician. This is the language from the law. It's very physician-centric, but the process leading up to it is multidisciplinary. It requires a recorded oral request on audio or video that becomes part of the medical record, requires a written request with 2 adult witnesses who can't be members of the patient's family, can't be in the medical institution in which the person is seeking medical aid in dying support. There is an eligibility evaluation by a MAID consulting physician, an independent evaluation for both prognostic eligibility, capacity, informed voluntariness. And a capacity evaluation is required in New York State, as 2 other jurisdictions, by every person who is on this MAID law process. These first 5 steps are flexible in their sequence. It is possible for example, I'm speaking with hospitalists on Friday. It's possible for a hospitalist to reach out to me with a patient who's seriously ill, with whom they've had a deep conversation and have determined that this person truly in earnest qualifies for, is eligible for, has a capacity to make a decision about aid in dying. And that hospitalist could be the consulting physician who reaches out to palliative care for deeper exploration. If the patient chooses to move forward after passing these 3 doctor-level eligibility and capacity evaluations, the attending can write a prescription if that feels right in the moment. And there's a mandatory 5-day wait before the medication can be filled. And then the patient has the option of self-administering, and repeatedly the law says, and it just seems so clear, the patient can rescind this plan at any point. I'll share with you just a little bit about the prescription. There is no one standard, but there are folks who have studied this intensively, and it might sound so extreme, and it does to many, that we're talking here about fashioning a collection of medications that has a high reliability in inducing sleep and coma very quickly and reliably causing death on short term. The combination that is best tested includes this combination of 5 medications. It's mixed in powder form. It's filled at selected compounding pharmacies. UR Medicine's strong compounding pharmacy is signing on to be one of the compounders for this medication. It's prescribed by the MAID attending by the law as the MAID day nears, not when they become eligible, because many people choose not to pursue the medication ultimately. It's not covered by insurance. Across the country, it costs typically $500 to $1,000. Your medicine is finding a way to bulk order these medications that will be less expensive and yet still not trivial. And the patient has to be able to self-administer. And by practice, this has meant by ingestion. Anything using the GI tract, generally orally. It can be delivered by G-tube, gastric tube. It can be delivered rectally. And its impact, so here are some hard numbers to look at, but the mean and median time to sleep in coma, 5 to 6 minutes, time to death, 0.8 to 1.6 hours. And you'll see here this pie chart noting that the majority of folks who die within 2 hours, but a fair number live for 2 to 5 hours, and a few as many as 20 hours or even longer. They are in coma the whole time, but you can imagine what a challenge this might be for family who are sitting by the bedside or for professionals. So the guideline at URM Strong in Highland includes these following, in addition to the policy which recapitulates the law I just shared with you. Patients may inquire about, discuss, and request MAID anywhere through the institution. Participating in the law process is voluntary for clinicians and staff. There's no requirement that they do so. The guideline is very clear about this. People can opt in, can opt out at any point along the way. Self-administration of the MAID prescription ordinarily will occur outside of UR facilities. The law does allow, and the institution does allow, the possibility that a MAID ingestion could happen within the facility, but that is complicated logistically and in terms of safety. But it's possible, it's not prohibited. And then each department, division, and practice setting defines how it will engage with the New York MAID law process. So I'll close with just a couple things. So the question of how will you respond to seriously ill patients who raise these questions about aid in dying or existential expressions of despair, people are asked to, and I'm encouraging folks to consider their scope, their setting, their expertise, and their conscience. And so at each step along the way, depending on setting, MAID curiosity are questions around what is this? And so the response is, tell me more, what's on your mind? There's a large number of folks who have basic questions about aid in dying. For deeper personal consideration, this does require more expertise, more skill in really exploring this person's values in the context of their illness, as we described earlier. For those who earnestly choose to pursue the MAID law process, I wish to do this, that requires yet more expertise and will be a narrower band of folks who are willing to engage in the process. And ultimately, for those few folks who decide it's time to ingest medication, this will be a deliberation with those who choose to support that process as prescribers, as referrers, as sitting at the bedside supports. So there's a lot of education and support available for people who are interested. The UR Medicine MAID policy and guideline are coming, I think, today or tomorrow. on policy stat, the policy will be up. That's a truncation of the law. The guideline, which offers a lot more information as what I'm sharing here right now about engaging in conversations with folks who are curious, and conscience clauses coming in a couple weeks. Up to Date has a great article. It's available on Epic. It's available widely on the clinical considerations of medical aid in dying. I'm encouraging all my colleagues who have interest in this, who may engage with patients who are curious, to at least spend those 30 to 45 minutes to learn that well. The Academy of Aid in Dying Medicine has some great free resources to help clinicians and others learn, including community members. There are MAID reflection and support rounds that Margie Shaw in Ethics is hosting on the first Thursdays of each month on Zoom for anyone who's interested, who's engaged in the conversations, worried about this, struggling around any part of it. And we in palliative care have weekly complicated patient rounds, CPR rounds, named ironically, that on the third Thursday at noon will focus on MAID-related issues. There's also a lot of education and support for patients who are interested in learning more and for the community. So with that noted, I spent my 20-some minutes and I'll stop sharing.
Thank you, Rob, for that really, really thorough and very timely and thoughtful presentation. I think a lot of people here might have thought you're going to get a cookie cutter of what a law would be, and I'm happy to see that Rob expanded beyond the paper and the law, and really to think more about us as clinicians too, and our part and our role and our own biases and influence in these decisions that we make. With that in mind, George, in thinking about, I know you're in part of the policy for the guidelines that come out. Have you begun to think, and I know this is down the line, when somebody really is in the process of the law, have you begun to think about how will you decide decision-making capacity in these cases? And who might be participants? Would it be, which was not covered here, would it be psychiatrists? Would it be, who are the mental health professionals that the law calls for?
Yeah, thank you, Telva, for the question. So the law is clear in terms of who can participate as a mental health professional in this process. As Rob was mentioning, that in New York State, every single individual going through the process, the MAID process, will need to have all three components, the prescribing physician, the consulting physician, and a mental health evaluation for the purpose of determining capacity. And in the statutes, it's clear that the people who can do that third step is physicians who are board certified in psychiatry and neurology, so that's usually psychiatrists and neurologists. There's some debate whether neurologists should participate in this step or not. The statutes kind of is vague around that, and doctoral level psychologists. So for our purposes, it would be psychiatrists and psychologists who can participate in this step. So that kind of excludes master level therapists or APPs who clearly are not eligible to determine capacity for the purpose of the MAID process. In psychiatry, we have identified a core group of individuals, psychiatrists and psychologists who are interested in participating in this process. We have met several times and had conversations about, how we could be part of this process. The statutes really are kind of restrictive about the role of the mental health professional. Basically, it says that the role basically is to determine capacity to engage in making an informed decision about this process. So that's what we are here to determine. At the same time, it's very important to understand, that's how I understand the whole process, is that the MAID process is a team-based approach. What I mean by that is that capacity evaluation is going to be determined at multiple steps throughout the process, including the mental health evaluation. Voluntariness, or the person's making the decision in a voluntary way without coercion, is also being made at multiple steps by different people, including the mental health professional. So although the statutes say that the capacity evaluation is an independent step, which it is, it also takes into consideration that the person in front of us has gone through all these different steps, and multiple people have determined, their qualification, their capacity to make decision, have offered information to them about the process, alternatives, different things, have had conversations with them. And we, as mental health professionals, come as a last step to determine that capacity evaluation, which basically we do for a number of other people. We do capacity evaluations for people who want to stop dialysis, or capacity evaluations when people want to refuse treatment on an inpatient unit, refuse surgery, want to leave AMA. So there's a process to determine capacity, and we're going to use similar process where we go over whether the person is making a choice that is consistent over time, whether the person is understanding the information that was provided to them, whether they appreciate the information or what they have received, can they apply that information to their own circumstance, and whether they have the ability to make a reasoned, notice I didn't use the word reasonable, a reasoned decision-making process, meaning they apply a logic to how they arrived at their decision-making process toward the end. Those are the four elements of making a decision, and what we use to determine whether they have capacity or they don't have capacity.
Thank you, George. I just want to clarify, could you expand just a little bit, just to clarify that the law, when it talks about dying from an illness, is a medical illness. Mental illness is not a primary diagnosis for meeting MAID criteria. Is that correct?
That is absolutely correct. Actually, in the statutes, there is a statement that says that diagnosis is not enough to make a person eligible for MAID. So the attending physician and the consulting physicians are making a determination that the person has a terminal illness or condition that is, within reasonable medical certainty, going to cause death within 6 months with or without treatment. So psychiatric conditions don't really enter into that equation.
Thank you. Thank you. All right. Very good. Thank you. Could we have Dr. Conwell's slides, please? Dr. Conwell, given your expertise in suicidology, can you expand a little bit on what you think each mental health professional should consider as they make this decision to participate in MAID? And what do you feel is essential for each professional to arm themselves with in order to participate in making this decision?
Yeah, thank you, Telva. Well, first of all, I'm speaking to this issue as a geriatric psychiatrist. My focus is on older adult mental health, and older adults are the significant majority of people in the state of Oregon, at least, who have taken up MAID. And also as somebody who has spent many, many years thinking in depth about suicide. And so these things come together for me at this point in time, trying to think through and provide some clarity in how we think about the overlap between MAID and suicide. And the way it's typically presented in the literature is of a Venn diagram, basically, not this one, but another in which you've simply got two ovals, two circles, and they overlap, and one is MAID, which is fairly straightforward in theory, and then the other is a suicide, which is what many of us are very familiar with in mental health, and we deal with it on a regular basis. And then this overlap, and honestly, nobody knows how large that overlap is or what happens in that box. What I'd like to struggle with a bit with you all is addressing those people in the audience and elsewhere who are potentially eligible as mental health professionals to provide this assessment, which contributes to the ultimate decision of whether somebody seeking MAID has the decisional capacity to do so. And let's look at that question of suicide and its overlap with MAID. And we've this is something, just a tool called the 5Ds that we use in thinking and helping order an assessment of suicide risk in older adults. And it's based on a lot of evidence, a lot of it accumulated here through our Center for the Study and Prevention of Suicide. But it's these 5Ds, and it has a very simplified way of thinking about it. The first is depression, which we know to be a serious risk factor for suicide, whether it's syndromal or subsyndromal. And of course, depression is very common in people with medical illness and with terminal illness, and it is also associated with impaired decision-making capacity at some level. So that's one of the decisions that needs to be assessed. If depression is there, is it contributing to decision-making capacity impairment? Second being disease, which is the D for medical illness in our nomenclature here. And of course, by definition, it is there in people who are seeking MAID. Disability, which is functional impairment, again, something that we know from careful research does contribute in older adulthood to increased risk for suicide, and which is, I think, present to some degree either in reality or the fear of becoming functionally impaired in people who are considering MAID. The third, I guess it's the fourth D now, is disconnectedness. This is a subject of a great deal of ongoing research, as there's an appreciation of the prevalence of loneliness, lack of belonging in the population at all ages here and indeed around the world. And the work of Kim Van Orden and many others really reaffirms the importance of disconnectedness and not feeling being part of something or being a burden on one's surround is a risk factor for suicide in later life. And then the last D being deadly means, and that's access to things like firearms, where older adults tend to gravitate. But the interesting thing here that we're dealing with, of course, is that MAID can become one of those deadly means. But there are many other factors at play, and maybe, Brian, if we could have the other slide there, just to add a couple of different factors that have been referenced here. But the point here is to underscore the complexity of this assessment for those of us who may be tasked with determining decision-making capacity for MAID in an older person. Indeed, I think this applies to any age, but in an older person who is seeking that aid in dying. And the reality is, while we know an awful lot about those 5Ds, including the very important observation that they don't work independently of each other, they work in combination. And so it's the interaction between each of those circles where the action is in making an assessment of suicide risk. And I would argue also in making an assessment of whether the MAID request is driven in some fashion by those factors that would have placed that person at suicide were MAID not available. And they are things like you see here, traumatic experiences with the death of a loved one. These are things that Rob, I think, very articulately mentioned are necessarily explored as part of that deep conversation. I've had patients who have become suicidal because they thought they had become a burden on others. I have had many patients whose drive to end their lives, including in the presence of what they thought to be terminal illness, was driven by not their own fear of pain and loss of dignity, but of what they observed in their mother who went through this serious, debilitating physical illness to death. So distinguishing between what is one's own, as a patient, fear and speculation from what one brought to that point in life from prior experience is a critical issue. Family conflict, again, that sense of being a burden on others, which is so common in older people, and I would argue complexly exacerbated by the care needs of an older person in a terminal phase of illness, the demands, perceived or real, on caregivers, often children, for example, or the financial cost of draining one's resources that they hope to be a legacy for their children, or on and on. Those kinds of things need to be very carefully and deeply explored. And what else we got here? Oh, biases, ageism. We know it's there. I mean, you see it on the TV and in print media every day about the need for older people kind of to recognize when their time has come. And again, an important nuance to that is that's not just what society tells an older person, it's what that older person who has been raised in that society tends to feel about their own self-worth. And then cultural mores. Again, that's beyond ageism. I've done a lot of work in China over the years. Fascinating place that gives an insight, I think, into the impact of subtle social expectations. An older person in China is often born in and continues to live in a Confucian cultural milieu in which they are revered, oftentimes, the older person, and yet simultaneously, because of demographic shifts and the socioeconomic implications of that, the Chinese government has a requirement that younger people take care of those older people. It's in the law. What if you don't do that? So you're required to do it. And what kind of anger, burden, complex relationship issues that relate to how end-of-life decisions get made then are actually embedded in that social contract. So all of this is going on, and I just want to underscore that anybody who, in our position, considers participating in MAID as that mental health professional charged with making that decision about the presence of decisional capacity has to deal with all of this stuff and figure out how it may or may not be impacting decisional capacity. Recognizing that there may be treatable conditions here, be it through family therapy or through pain medication and treatment of depression, or by psychosocial as well as medications, and on from there. So we have to decide. We think that there is a potential treatable illness here. Is it impacting decisional capacity or not? All decisions that we may disagree with or be uncomfortable with on the part of our patients aren't necessarily wrong, and they aren't necessarily impacted by impaired decision-making capacity. So there's a lot going on here. I think we need to be very careful, very aware of our own biases, leaving them at the door when we come in, very aware of our own values and appreciating that they cannot interfere with our objective ability to make these complex assessments in many different ways. And then do we have the experience and the know-how to reliably make assessments like this that contribute to this this team-based decision in a potentially very powerful way.
Thank you, Dr. Khan. Well, that was very profound, very thoughtful, and I think you touched on a lot of the points that we wanted to bring up. With that in mind, though, and thinking about the question about risk of countertransference or unspoken unconscious biases that might influence or impact implementing this law, there has been documentation elsewhere where these biases tend to impact the law. And I'd like to ask Dr. Scharf, could you describe these concerns and how it affects us as mental health provider in this multidisciplinary decision-making capacity that we have to participate in MAID?
Yes, I'm happy to do that. Should I turn my microphone on?
I think you're on.
Okay, good. Thank you, Telva. I've actually talked about this with a number of people, and some may wonder how it makes sense for child psychiatrists to be part of this panel in this role. This is actually almost exactly 29 years since the first time I really thought a lot about this. Literally in the first half of the academic year, 29 years ago, I did a rotation with Dr. Quill, who you heard about earlier as part of my fourth year, focused on palliative care. And as part of that time, I worked closely and got to know Dr. Horowitz, who is who you heard from first. And then in the very next block, I did a rotation here in our psychiatry department, part of which I got to know Dr. Conwell and sit on one of the groups that was doing psychological autopsies. And at that time, what was most commonly referred to as physician-assisted suicide was very much in the news. So we talked earlier about this being 6 months since the legislature till now, but my perspective has been this has been an issue that has been discussed in many circles throughout my entire career. And not only do I come to this in my professional role, but like I imagine everyone in our audience with a large social network and a big family, people I care about and I love who I've watched and been with as they've gone through terminal illness and death. The concerns that I have are really they're largely theoretical, and if the people you're hearing from today were the ones carrying out every step of the process, I think are not that big of a concern. But I've also seen through my career how things that are not intended to be, and Rob used the term that I like, checklist eligibility transaction, becomes a checklist eligibility transaction. Who are the people that are going to volunteer to be the witnesses, the non-connected witnesses to people's statements, and how many are going to say, it's not a valid statement? Who among us as the psychiatric professionals that are going to do the evaluations are not going to come into it with a history and a strong perspective, maybe even strong feelings based on lived experience personally or professionally? This would be the parallel to what Yeates talked about with people making decisions influenced by what they witnessed a parent or another loved one go through, arguably when healthcare wasn't even the same, might not have existed for the condition the person's facing. I think the structures that we've talked about, particularly the things that are in addition to the law, can largely mediate this, but I think we need to be mindful of it, of these things for it to do so. The idea of coercion has been talked about, and that this can't be a coerced decision. Coercion is an interesting word that I think most of us feel like we know what that means. My hope is that the approach we actually take is more about guarding against undue influence. Those many I see in the audience who's here live, and I'm sure there's some others on Zoom who have worked with me clinically, and you've probably heard me refer to coerced voluntary placements or decisions. And it's also a big enough audience that I bet some of you have either had professionally or maybe personally experience with teenagers who've been in residential settings. In New York State, by definition, every single one of those for every night they slept there was voluntary. How many of those teens, now young adults or middle-aged adults, will describe their experience as voluntary? So I think that it's not just a word of it being voluntary or not, but really a thoughtful process that we want to bring. It was already referred to, the idea that someone could be worried about the impact their illness and caring for them has on relatives, I think is a very real issue, and I would never make light of it. And I want to encourage each of us to think about our own reactions. If we're presented with a scenario with the person who's contemplating this decision or talking with the physician about it, if the first thing they say is, I need to end this process, I need to end my life because it's a burden for my kids. Well, what's our first reaction to that? I suspect for most of it's like, oh gosh, well, even if it's hard, shouldn't the kids fill that role? Shouldn't they take on that burden? Wouldn't I want to? And yet, if you live long enough, you will see situations where it is a burden on those kids. And I don't know that it's unreasonable for a parent to consider that burden, that impact. The challenge is, how do they really know what it is? How do they really know what the impact is, and whether the person would, in fact, welcome, if not at least tolerate, that burden to be a caring child? Well, the answer, I think, is to talk about it, right? And inevitably, we will end up in situations that could be less clear. But there are things we can do in our processes that I think will help. My biggest worry, and I've expressed this with everyone I've talked about this, is that the process can become a one day or a weekend process. Now, no one said anything today to suggest that. No one planning at the University of Rochester is contemplating that. And I've also seen online ads for ketamine where it directs you how to fill out the PHQ-9 to be depressed in order to come up for your single appointment and be handed your ketamine. I think that these processes are really important, and if we can include an idea of a longitudinal assessment, something that I think will happen, George referred to that there's no way this can happen as a team-based activity that's not longitudinal. I think we need to be very mindful of that. If we have assessments that are done on one day at one point in time, I think that's where some of the things that I and others have expressed concern about can play out negatively. Another thing that is absent from the rules, the law, our conversation, but I wonder if it might be worth thinking about or introducing, is the idea of relationship longitudinally with caregivers. Telva and I, even before this law was an issue, have talked many times about the idea of some psychiatric conditions, in fact, being terminal illnesses. But as we think about that, is someone who's meeting a person for the first time trying to assimilate all the information in their chart and that's handed off to them in an emergency room in a position to decide that? Or would it be a clinician who's worked with someone closely over many years in the context of a career of even more years? I'm much less worried about this in the context of a longitudinal relationship with clinicians. I worry that if you have to figure it all out on one day, never having met the person before, assimilating all the information, that a lot of these challenges can play out. I'm going to pause so we can have some questions.
Thank you. We're going to take some questions from the audience, and there's a couple online, if you don't mind. I want to just, first of all, before we I'll leave just to thank the panel for their excellent thoughts and presentation. No real answers today, but a lot of things to think about. And I think this is a very serious step in the law, and we need to acknowledge that and take it very seriously. And I hope we have more conversations like this so that each of us has an opportunity to tease out where we stand on these issues. Any questions in the audience? Yes, Joyce.
Yeah, so thank you. And as George, when you're describing kind of how the capacity assessments from my field psychiatrist, that I'm curious what the statute dictates for patients who decide to rescind their decision and reapply. We know that had been, there's case examples of that from other countries. And, we think generally that that is reflective of lack of durable wish when there's a flip-flop of decision. In fact, there is a case like that where CL and ethics are heavily involved in the patient right now. And so is there any guidance around how to evaluate capacity for a patient who rescinds their decision and presents again later down the road?
Yeah, that's a great question. And then the short answer is no. And I wouldn't look at the statutes for guidance on that, to be honest with you. What you're saying is extremely important. Flip-flopping in decision-making is part of the decision-making capacity evaluation, right? But that's different from someone who has entered the process, has gone through a verbal application, a written application, witnesses, and then the statutes will say that at any point after that, they can rescind the application if you want by any means, right? So they don't have to write to go in writing, and they can rescind that application. So rescinding it is different from flip-flopping, and that's up to us as clinicians who have done evaluations to make the difference.
They're having rescinded.
When they re-represent again for another evaluation, yeah.
I would like to see.
Yeah, so that's up to us as clinicians to make, that's the complication of this whole process. Yeah.
I think it's an opportunity for an even better assessment.
Right.
And could I just add the idea of ambivalence that
Right.
Ed Schneidman, a psychologist who studied suicide forever, insisted, and I fully believe it, that there is no suicidal person who doesn't have ambivalent feelings about death.
Yeah.
This doesn't happen.
Janelle, do we have a question?
Yes, we have quite a few. And while we may not get to all of them, we will follow up with all of you afterwards. So it looks like the first one might be for Mike. How does the law affect terminally ill children and minors?
I don't believe there's any specification of age, but the idea of defining the law for 18 and above. Point I was going to make is that I think the most important aspect of this in consideration and process is the definition of terminal illness, and the law is for adults. And again, I've been at this long enough. It would surprise me if there's not people arguing for adolescent consideration or exception within 2 years, and then from essentially documentable cognition, probably within 5 to 10 years.
I think that's coming. And children also grow up to be adults with serious illnesses.
Absolutely.
Right? Might transcend the 6 months, but nevertheless, it depends on so many factors, really. Yes.
If you had a recent suicide attempt, does that make you ineligible for this? And if so, then how do we define recent? Because I imagine there are people that meet this criteria for a terminal illness within 6 months and try to do something themselves before considering or applying for MAID.
Yeates, you want to take that?
Sure. I think that it's important to separate that and to do what one would do anyway, which is to try to determine what was the driver of that suicide attempt? Is it distinguishable somehow? Is that an indication of impaired decision-making capacity that is related somehow to what those stressors were that precipitated the suicidal act? That kind of thing. No, I don't believe that would preclude a decision in support of that individual's choosing MAID, but it certainly would raise the likelihood of underlying issues perhaps needing to be considered.
Questions from the audience?
Yeah, so we have a quick comment or really question. Are the slides available? And if so, how do we access them? If you reach out to my office, I'm happy to send you the slides along, and that should be attached to your invitation. The last question, and we have several. What will it list on the death certificate as the cause of death?
So that is actually in the statutes that there's a distinction being made between people seeking medical aid in dying and people seeking suicide. So there is a whole section of the statutes on the fact that on the death certificate, the cause, the illness itself will be listed as the cause of death and not suicide. There's also language around precluding insurance companies from discriminating against people who are going through this process, life insurance companies from discriminating against individuals going through this process. So there's a clear distinction in the statutes, although I understand and respect what Dr. Conwell is saying. In the statutes, they're making that distinction that this is not suicide.
That's, it seems like I have one last clarification, and that has to do with, I forgot now. I'm gonna say goodbye. I'll ask you later because I can't remember what it had to do with, but, well, I just want to thank the panel for being here today and really enriching this conversation. Marjorie, thank you for all the work on this. From the ethics point of view, you're valuable in these discussions. Thank you for participating. Dr. Horowitz, thank you very much for attending and giving us an excellent presentation despite your illness. And we hope you get a speedy recovery. Thank you, everybody. Bye-bye.